The individual that asked this question operates a large assisted living center for seniors, and not every senior in the assisted living center has dementia, but there's a fair amount of cognitive decline and maybe neurological challenges that are occurring. And so this manager says, Randy, what can we do? Is there anything that we could add that would strengthen our ability to take care of seniors? And it was such a beautiful statement because I could tell they're just searching for, is there anything that we're missing? So that's the stimulus for our discussion today. And I want to talk about dementia from two sides. The first one is my good friend Eric, who you just heard from, spent 16 years as the executive director in an assisted living and memory care center, and he is recognized as a national expert. You just heard him say he just returned from Iowa, where he taught the medical director, a physician, and the ownership group of a very large community of seniors, because for the same point, we're trying to help our seniors age gracefully. Eric developed something called the Vital Five. And I won't spend time talking about the Vital Five other than to say that this is his proprietary approach of how he communicates with individuals who are struggling from cognitive impairment. On the other hand, I spent 10 years as the director of a skilled nursing community. That's a fancy term for a nursing home. And I chaired the Psychotropic Drug Review Committee. I was chair of the Pharmacy and Therapeutics Committee together with a pharmacist. I've owned urgent cares and family practice for 10 years or for 20 years, and I very much have a functional approach. Menopause has been a big part of my care, and I'm going to circle back to menopause. I'm the author of the Enhanced Protocol, which is an approach for how we support individuals, many of whom are not living in a senior living center, but we could support those individuals through that same Enhanced Protocol. And we've developed the Person-Centered Review, which has been on my mind for several years. I've made various runs of this. Eric and I made a run of trying to do a person-centered review. This is how we take an individual who's already living in an assisted living center community and help them do better. We started doing this in 2016, 2017, had contracts with assisted living center, and then those faded away with COVID, because with COVID, everything faded away, right? It changed the world. So now we've regrouped and we're working on how to implement this in many communities nationwide. And I can tell you that when you combine those two approaches, a really individual-centered review with the Enhanced Protocol and the Vital Five tools that Eric has developed, it's magical. It really does improve and change the lives of our seniors. But see, we're not alone in this. Sometimes when I talk about this, I make myself sound bigger and badder than I really am. The reality is the science of dementia care has been talked about from a lot of places. This doctor on the bottom left, his name is Richard Isaacson. And Richard Isaacson started the Dementia Prevention Clinic at Cornell. Now think of that. 10 years ago, there was no such thing as a dementia prevention clinic. They didn't exist. We didn't think there was anything you could do to slow it down or prevent it. Doctors Schurzai, both of these doctors are neurologists. They're married, and they run a very large practice in the Blue Zone down in Loma Linda, California. And they've written about their approach for an Alzheimer's solution. Phenomenal. Dr. Bredesen, I talk about him a lot. I traveled to Dallas, Texas in 2017, met him face to face, and listened to him lecture for 3 days on ending Alzheimer's disease, what can be done. From that, I developed the Enhanced Protocol. And then from that, we have springboarded into introducing these particular tools in memory care, assisted living, and all types of senior living. So I want to talk for just a second about a needs analysis of a senior. Look at this beautiful woman that's at the center of this triangle. This woman, let's make the assumption that she is no longer able to live independently in her home. Now, my goal is that everyone would be able to live independently in their home until the good Lord calls them home, to heaven and they move on to the next phase of eternity. But that doesn't always happen. And when an individual moves into a community, they're affectionately referred to as a resident, and they have very specific needs. These residents need a lot of love, a lot of attention, a lot of assistance. They often need help with hygiene, support. They need food and shelter and kindness. They need meals, 3 meals a day, an activities program so that they don't just sit there in silence or sit there in front of a television. They often need someone to administer their medicines and do their laundry. They need access to medical care because they can't drive anymore. They need socialization and dignity. Even though they're seniors and they've lost some of their capabilities, they're still people. They still need what you and I need, but oftentimes they can't voice it. They can't articulate it very well. They can't tell you what they're struggling from. They need safety and engagement and grace from their caregivers. And I'm so grateful that there are assisted living centers that offer all of these blessings to these individuals. But at the outside of this triangle, there are family members that have needs too. Let me talk about those needs. I can't pretend to know all of them, but I can certainly tell you what my experience is as I consult with family members and spouses and loved ones who are taking care of seniors who are losing their cognitive functioning. They need a guilt-free experience. They don't want to feel like they just put their mom into a home that they're not happy with. They want confidence that individual needs are being met. They want their loved ones to be as comfortable as possible. They want a clean environment. They have very significant expectations of, is the room clean? Is there housekeeping? Are the meals good meals? Is the environment attractive? And they want to preserve the dignity and the identity of their family members. Well, the communities that they reside in, guess what? They have needs too. This isn't just all about the residents. The community actually they have to have a census. They have to have residency in order to run that community. You see, if your community is only half full, they still have to pay a full-time cook and a full-time laundry person. And so they're trying to figure out, how can I have enough people in this community to actually afford to provide the services? We have to afford caregivers and nurses and dietary staff. We have housekeepers and training. We have to train all of these staff members. A new staff member will come and go, and they have to train the new ones how to use the equipment. Where do you find things? How to answer tough questions. These communities have to have management support and marketing support and operational support, human resources. This is so important. Well, guess what? There's a third part of that community that is so important. It's a hinge pin, and it's the doctors or the nurse practitioners that call on those communities. And those doctors need community support. I can speak about this firsthand. I would receive calls at all hours of the day and night saying, Randy, our beautiful resident fell today. I think she broke her hip, or she fell and hit her head, or she lashed out at somebody, or she won't let us help her change her clothes or shower. What can we do? I always needed accurate information. So when they call, I would always say, have you checked her vital signs? Did she receive her evening medications? What has changed? I relied on them to convey this information over the telephone because I often couldn't just run in, stop what I was doing to go into the community to address those emergencies. As a healthcare provider, I needed it to be efficient. It didn't work very well if they called me and said, we need your help. And I asked them a question. They're like, well, hold on a minute. Let me go find their chart. Hold on a minute. I'll call you back. Let me call their daughter. No, I needed them to have data and information at the time of their call to problem solve. I needed some level of predictability. I needed to be able to say, I can come on Mondays and Wednesdays and see clients. the relationship to me had to be a financially viable relationship. Even though I loved that role, it wasn't just a service that I offered. I got paid to do that service. And oftentimes I felt like, my gosh, I've put in hours and hours of work and I'm just not getting paid very much. So the financial viability has to be there for a healthcare provider. I needed it to be low risk. I did not want to feel like every time I engaged or did something that a family member was going to get angry and then try to sue me or report me to the board of medicine. You can see that everyone that participates has needs. I needed to have good training. Oftentimes, I talk to individuals who run communities and I say, tell me about your doctor. And they say, well, my doctor's been an emergency room doctor for 30 years. Well, emergency room doctors are amazing at solving a problem. If you fracture your hip, you get chest pain, but they oftentimes haven't followed seniors for 10 years when they have dementia, and maybe they're less comfortable knowing how to manage that. So the efficiency in their training matters. I hire nurse practitioners all the time. And I remember I hired a nurse practitioner and sent her to the nursing home at the VA to see patients. And she called me and she says, man, I am out of my league. This is complex medicine. I need help. I've never managed congestive heart failure or chronic obstructive pulmonary disease. I don't know what to do in a crisis for a diabetic patient. So you see that these needs are a triangle, and each of these needs of the family member, the community, and the doctor have to be met for these individual residents to receive the care that they need. We can't do without a part of this. And when there's a breakdown in one of those parts of the triangle, the person that suffers is the person at the center of it. Those seniors either don't get good care, excuse me, they they struggle, they have crises, they have challenges that need to be met if there's a breakdown in there. So it falls within all of our stewardship and responsibility to minimize those breakdowns. That's where this presentation comes from. How do we do that? Every time I see the birth of a new baby and I hold that baby, I get this spiritual experience like, oh my gosh, that is such a miracle. This little baby was developed inside the uterus of his or her mother, and it's just the most amazing miracle. And as I was putting this presentation together, I thought it's no less of a miracle that all parts of that triangle fit together to provide amazing care for seniors in assisted living center. They're there in the first place because they didn't have the ability to have all of those parts of the triangle in their home. They needed help. So it's no less of a miracle at the end of life than it is at the beginning of life. But we have an opportunity to plan ahead in a certain way. Do you guys all remember? If you've had children, you probably remember bringing your child home from the hospital. You had doctors and nurses and all these people taking care of you, and you bring this baby home, and the baby starts crying in the middle of the night, and you look at your spouse and you're like, what in the hell are we supposed to do? I don't know what to do with this kid. I'm freaking out. What if the kid doesn't stop crying? I'm toast. I have felt that way so many times. The same exact feeling happens in spouses whose loved ones have dementia. It happens in communities with caregivers when someone's confused and they lash out and they don't know what to do. It happens with executive directors of nursing homes that have a panic attack. We don't know what to do with this person. I guess we're just going to have to send them to the hospital because we're stuck. We have to try to make sure we're planning ahead and solving those challenges along the way. So when a senior has a new onset problem that's related to dementia in some way, now that new problem could be they get super angry, or they get really tearful, or they yell out, help me, help me, help me, I need help, somebody help me. Maybe they don't go to bed at night. They sundown, their sleep-wake cycle gets disrupted, so they're up all night long, and then they want to sleep during the day, and the staff is like, oh, we can't keep doing this, it's so hard. Maybe they get aggressive and bite and scratch, but they need help taking a shower. or using the bathroom. It could be a number of other things. I want to talk to you about what typically happens in those instances. Now, I'm speaking from my personal experience, and I could be getting these wrong, so I want you to think about what I'm missing and type them into the chat box. Randy, you forgot this piece. So the first thing we do when there's an aggressive thing is we call the doctor. And we say, "Doctor, I need your help. My mom just did X, whatever X is. Here's the problem. How can you help me?" And the doctor will do a little bit of an assessment, maybe do some lab work, and then generally speaking, we offer a new diagnosis. We prescribe a medicine, and then we say, "There you go. We just solved your problem with a new medicine." A new diagnosis and a new medicine. If you've ever been on the other side of that telephone call, when I offer a new diagnosis and a new medicine, you felt like I felt when I brought my baby home and the baby was crying. Oh my gosh, what do I do? Are you kidding me? You think this is going to solve my problem? And oftentimes those new medicines bring with it side effects. So not only did I have a problem today, but now I'm guaranteed to have problems every day for the rest of the week because of these complex side effects from new medicines and new diagnoses that I just received. Let's take another scenario. Let's say that the problem is severe enough we're like, "Well, you just got to go to the hospital. I'm going to send you through the emergency department." Well, they get an assessment that's usually a little bit more aggressive than what a doctor would do, because now we have an MRI and a CT scanner. We have an in-house lab. We can run labs. They can stay in the emergency department for 5 to 6 hours until we get the lab results. So we do a lot more testing. But guess what? Functionally, the end result is almost exactly the same. We get a new diagnosis that kind of fits whatever behavior or challenge you just experienced, whatever the crisis of the moment was. Then they offer a treatment, and that treatment, most of the time, is a new medicine. Now, if they fall and hit their head and they need stitches, well, we sew them up and send them home with some pain medicine. If they were throwing up, hopefully we solve the problem of nausea and vomiting and we give them a new medicine. But guess what? Now we're kind of back in the same stinking boat we were just in. We kind of got a new diagnosis, a new medicine, and now there's some potential side effects. Well, let's take a different route. Let's say that we send them for a psych eval. I was consulting with a community on the eastern seaboard, the East Coast, Northeastern. And they said, "Randy, we typically send them out for a psych eval." So I thought through that. Okay, well, let's look at what happens when we do a psychiatric eval. Well, we do a symptom assessment. A symptom assessment isn't really a physical assessment. There's a little physical exam there, but we're looking at symptoms. What are they saying? What are they thinking? What's coming out of their mouth? What's their movement look like? So we're looking at symptoms. We offer an assessment. And I put on lab testing a negative because in most psychiatric practices, we don't do a lot of lab testing. There aren't a lot of tests that we would do in psychiatry that change the diagnosis other than rule out medical problems. Well, we already got that done over here. So it's actually a complexity where we go into a psychiatric eval and all we do is look at symptoms, and there's not very much we can do from a lab standpoint to help us make the diagnosis. So now we get a psychiatric diagnosis, which is a description of the symptoms. Now we get a diagnosis that says you're bipolar. Bipolar means that you're angry 1 minute and you're happy the next. You're psychotic and crazy 1 minute, and then you're asleep and you're calm the next minute. Or your speech is really rapid and you're going a million miles a minute, and then you slow down and you're kind of delayed. That's kind of bipolar. But does it make any sense to anyone on this call today that a senior who's never had bipolar disease in their life all of a sudden gets bipolar disease when they get dementia? That's a crock of bull. They don't have bipolar disease. That's just a term that we use to describe the symptoms. But now we qualify for a psychiatric medicine to treat bipolar disease. And guess what? Psychoactive medicines come with a lot of psychoactive side effects. So we have to be careful of that. There's no such thing as a senior that's been healthy their whole life that all of a sudden gets schizophrenia when they're 80. That doesn't exist. But I see it all the time. I see these psychiatric diagnoses on seniors that spent their life as engineers and nurses and doctors and city managers and accountants. And all of a sudden they have a psychiatric diagnosis. No, look, something's wrong there. That's not a true psychiatric diagnosis. That is a description of psychiatric symptoms, symptoms that the brain is sick. Well, what's another thing that we can do? I see this a lot. When our seniors get to that point where they start having behaviors that we don't know what to do with, darn it, we just call hospice. Now, sometimes it's totally appropriate. I am a fan of hospice. Hospice can come in and manage a dying senior with dignity. It's amazing. I'm grateful for it. But sometimes I wonder if we use hospice services because we don't know what else we could ever do for a senior. And when we put them on hospice, we now stop all treatments. We keep doing some medicines, and we lose hope that there's any beneficial solution other than we're going to support them through the passing process as they pass away. We get a whole list of medicines that could treat any potential symptom that comes up. So if they get nauseated, give this medicine. If they can't sleep, give that medicine. If they're anxious, give them this medicine. If they have pain, give them that medicine. I want you to know that I'm not critical of that model, not for 1 minute. I have seen the beauty and the majesty of hospice. What I'm critical of is when we use hospice as an approach to address complex challenges for which we can't figure anything else out, and maybe there is something besides psych meds. And most of you who have ever had an experience putting people on hospice will recognize and will say, I've seen this. As soon as we take them off all their complex medicines, they rally and they do amazing. And we're like, what the heck? We put them on hospice because we thought they were going to die in a month. And all of a sudden they rally because we got rid of all of these other complex medicines that had terrible side effects. And we're like, whoa, I thought this person was going to die. Now all of a sudden they're eating and talking and sitting at the table and smiling and interacting with us. And that was not how they looked 2 months ago. That's a rally, probably from adverse side effects of medicines. So where does a Mind for All Seasons come in? If I've talked about the problem, I darn well better have a proposed solution. What would I propose to do different in those instances? Well, my approach would be, hey, let's broaden the assessments we do. Let's do some really senior specific assessments and some baseline testing. And then, darn it, I'm going to be proactive. I'm not going to wait for the senior to have a crisis where they lash out and bite and hit and kick, because I know the moment they have dementia, that's coming. I know that's coming. It might be 6 months down the road or 6 years down the road. But why would I wait until I have a crisis to address it? I want to be proactive, and I want to use translational medicine. Now, some of you have never heard the term. What in the world is translational medicine? I'm going to spend a few minutes and tell you what that term means. It's a term that's used a lot in medicine. You've got to understand it. And then once I am proactive and I use some translational approaches, then I make adjustments based on the outcome of the individuals. And I can tell you that this too is an evidence-based approach. I have a very, very dear friend who's a psychiatrist in Arizona. And he says, hey, Randy, I only want to practice evidence-based medicine. So when you talk about these approaches, you better give me the research that says, where does that evidence come from? And I'm like, darn right, I'll give you the research, dude. There is research basis to these transitional or translational proactive approaches. So let me talk about that for a second. I want to define these terms for you, not just have you assume that you understand what I'm mentioning, but I want to actually define them. A proactive approach means that I'm acting in anticipation that I'm going to have a future problem. And it's very different than the standard of care, which is a little reactive. right? We just use medicines and make the assumption that people are going to fail, and we become very reactive in our approach. I want to apply a lot of proactivity. If I apply proactivity, patients do better. Translational medicine means that I'm translating scientific discoveries from diagnoses that have been used in clinical practices for other like diagnoses. So, for example, what works in the head injury world sometimes works in the Alzheimer's dementia world. What works in the menopausal world sometimes works in the Alzheimer's world. What works in sports medicine can be translated into Alzheimer's disease. That's what translational medicine means. And I'm going to give you some examples of that. And in order, sometimes people get the idea when you use extreme. So I'm going to use some really extreme examples. This guy right here in this family picture was a NASA engineer, the good old red-blooded American family. And this really nice mother was devoted to this beautiful family. She ended up murdering all 5 of her children in South Carolina many years ago. You probably heard about the story. It was tragic. And so the reason I'm using this example is here is a devoted, good woman who had a psychotic break and lost her mind, and really bad things happened. Let me tell you how this translates into Alzheimer's disease. Okay. Her name is Andrea Yates. And when we're done, you should Google her or read her story in Wikipedia or go to YouTube and read about the Andrea Yates story. She graduated valedictorian of her high school. She was a National Honor Society member. But in high school, she struggled with a little bit of eating disorder and a little bit of depression. Never attempted suicide, but she struggled with some depression. She plugged her way through it. She goes to college. She became a registered nurse and worked at the University of Texas Health Sciences Center for 6 years. Very devout Christian mom, and by all reports, loved her family. But this woman had the most debilitating postpartum depression you can ever imagine. She would have a baby and in postpartum depression would get psychotic. She'd start shaking and she'd start chewing her fingers off, and her husband would take her to the hospital. She'd attempt suicide. She'd be hospitalized. She'd come home. She'd be on psych meds. And then she'd threaten suicide and attempt it again and go back to the hospital. This happened baby after baby after this wicked postpartum psychosis. She ended up being catatonic. She started mutilating herself. And one day after discharge from the hospital, her husband goes to work at NASA, and his mother is on the way to the home. This short window between him leaving and mother and his mom coming to the house to help support her, and she drowned all 5 children in her bathtub. I mean, the story couldn't be more tragic. Now she's spent the rest of her life in prison, right? She's in a moderate security building because once they addressed the psychosis, she did okay. Tragic story. But here's the translational approach. Why in the world would I share this horrible story with you guys when I'm talking about dementia? Because in postpartum depression, look what happens. Your hormones during the pregnancy surge, and you get to this huge level of hormones, and all of a sudden you deliver a baby right here, and then your hormones drop to menopausal level overnight. Boom! You're menopausal, or the equivalent of menopause. And in many women's cases, that leads to the most aggressive depression, I feel horrible, and psychosis. In this case, it cost the life of 5 beautiful kids, destroyed a family, right? Well, why do I bring it here? In translational medicine, did you know that if women have a hysterectomy early in their life and they take both ovaries and their uterus, it increases their risk of dementia? This study was done at the Mayo Clinic in 2011, and the study says when you compare women who've had no gynecological surgeries with women who have had gynecological surgeries, the women who have had those hysterectomy, those gynecological surgeries, have greater risks of dementia. And it's because the brain is so activated neurologically by those hormones. Hormones are not just for sexual health or reproductive health. Look at the bottom statement right down here. Estrogen therapy may partly offset the negative effects of surgeries. They do better. So the translational piece is, why aren't we using some of these hormones in our senior women with dementia? Their moods get better. They have less psychosis. They deteriorate less. They sleep better. It's amazing. This is a translational process that we should be doing. It's been talked about ad nauseum. This doctor right here, Avram Bluming, he is an oncologist, and he says taking hormones in menopause can improve women's well-being and lengthen their lives without increasing the risk of cancer. This is not happening in senior living. It should be. It's translational medicine. Why aren't we using hormone optimization as an intervention to improve the lives of our seniors at risk for dementia? Because we know where it ends. It ends with antipsychotic medication. That's a trouble. We should be proactively using these medicines the very moment that they have some cognitive impairment. Here's another example, translational medicine, a great book that was written by this doctor. His name is Michael Lewis. He talked about how do we treat post-concussive syndrome. And he talks about really high dose omegas. When you use omega-3s, the brain changes. Why aren't we using more omega-3s? Some of you might say, well, I do use omega-3s. Have you ever tested the omega-6-3 ratio? Have you ever measured how much omega is in the bloodstream? There has been research that shows a correlation between suicidal thinking and major neurodegenerative disease from low omegas, and the standard American diet that's loaded with omega-6 often perpetuates that. So my question is, are we checking those levels? Are our seniors, do they have a very low index or a high index? Look at the difference there between a 2.9 and a 10.0. Every single one of our seniors with cognitive decline should have an omega index that rivals that 10.0. So why aren't we using aggressive omega-3 trials as an intervention for our seniors? I don't know. I think we should be. How about vitamin B1 therapy? This is something that I've come across just this year. I can't believe that I've missed this all the time I've been in practice. It's almost embarrassing to me. High-dose vitamin B1 therapy and Parkinson's disease. The research is amazing. And look at this right now. This is a $30 million clinical trial paid for by the Institutes of Health of using high-dose thiamine as an intervention for Alzheimer's disease. It's being conducted right now in 50 university sites nationwide. 50. Are we going to wait 10 years for those studies to come out, or can we just add high-dose vitamin B1? I mean, it's pretty stinking simple, right? How about translational medicine from COVID? Y'all remember COVID. It wasn't that long ago. We learned that if your vitamin D level and your zinc level was elevated, you had lower risk of decompensation from COVID and lower risk of death. That was proven. The spike protein wasn't as active if your vitamin D level and your zinc was elevated. Well, everyone was on vitamin D during COVID. Our seniors should still be on high doses of vitamin D, and we should check those levels frequently. I have a good friend whose daughter was admitted to the hospital. Her vitamin D level was 7. She had some infection. No one knew what it was, but when we checked vitamin D, guess what? We asked them to check. We requested the lab. When she got the lab and it was 7, the doctor says, okay, I'm going to start some vitamin D, and started 800 units. That patient probably needed 10 to 50,000 units right away. I would argue that we're, for the most part, underdosing our seniors with vitamins and minerals. That's translational science for Alzheimer's disease. So why aren't we using those? Let me tell you why. The standard of care has been dictated by the insurance companies. Here it is. They need to go to a senior living. We get a history and physical, and then we complete the admit process at the assisted living. We get physician's orders and a diagnosis. Sometimes we do a little smidgen of lab work. We want to make sure their sugar's okay. We want to make sure their cholesterol's okay. Then we get orders, and from there, the reactive approach begins. It's all reactive. A crisis happens, then we intervene and we start problem solving. Why did this happen? And then they go to the emergency department or they get a psychiatric consult, and then we add more medicines. And guess what? We go around and around and around. This seldom changes. I think we can do better. Would you ask yourself, don't you think we might be missing something here? Is there anything more we can do? Is there something that we haven't tried? Well, go back to this beautiful senior that I just showed you about. Oftentimes what happens is the family members go to the directors of the community and together they collaborate and they say, hey, are we missing something here? Are you telling me there's nothing more that you can do for my mom? Have we maxed everything out? Is there anything we haven't tried? Everyone who's on this call knows these questions get asked 100 times a week. There's an individual on our call today who just met me in my office who said, is there anything else I could be doing for my wife? And took copious notes, open-minded. Please help me figure out what more can be done for my loved one. Well, sometimes when these questions get asked of the doctor says, no, there's really nothing you can do for dementia. And I speak doctor. That's a language I've been perfecting for 20 plus years. And I think what the doctors are actually saying is, no, there's no successful medicine for dementia. There's no treatment specifically for Alzheimer's that's successful, but there are things we can do. So now let's get to the punchline. What are they? Well, this is what I think is being missed across the country. This is where I propose the solution. This is something that we've really been working on at A Mind for All Seasons, and I'll be the first to admit we're not perfect. We are working on this, and we are getting better every year that we're in business. The way we looked 10 years ago is not the way we look today, and I promise you, it's not going to be the way we look in December, nor the way we're going to look in July of next year. We just keep identifying and perfecting these solutions. So what we do is we get a health history questionnaire and we do baseline cognitive testing. And then we sit down with clients and say, hey, we really got to look at your diet. Maybe you need a continuous glucose monitor. Let's raise your proteins and your healthy fats, and we've got to cut back on your processed foods. Exercise is absolutely essential. So we do a mobility analysis. Can you go on a daily walk? Can you lift some weights? Can you ride a stationary bike? Can you do these things? Let's put this into your daily care plan. Oh, you wear a CPAP device at night because you have sleep apnea. Well, let's put you on an exercise device with a little bit of oxygen so that your recovery is amplified. You'll do so much better. Oh, let's talk about your sleep. Do you have sleep apnea? Do you have circadian rhythm problems? What's the environment like at night? Do you leave the TV on to fall asleep to a scratchy TV all night long? That's not very good for your brain. What are the social habits? How much alcohol are you drinking? Did you use tobacco? Are you using THC? What supplements are you currently taking? By the way, tell me about your dental health. We need a cone beam CT scan of that mouth. We got to know if you've got gingivitis or periodontal disease, and we're going to correct for those things right off the bat. Trigger identification. Now I'm going to go back to that history and physical, and I'm going to find things that stand out to me. We've done this for so long. I can look at someone's history and physical and say, yep, that added to their dementia. Yep, that's a contributor. And we teach communities how to do this. And then we look at all of their medicines. Just imagine if someone's on 15 medicines, they got a problem because some of those medicines they're on are treating the side effect of other medicines that they're taking. We just need to start cleaning house because they're not going to help them ever with dementia. I'm going to say that again. If they're on 15 medicines and they have dementia, they're not going to ever get better from those medicines. So we have to be thoughtful. We have to look at medication risk, and there's tons of tools. There's AI tools that now do that for us. All you got to do is plug and play. We do a nutrients analysis. So we're going to say, what's your vitamin B1 and your folic acid level and your vitamin B12 and your vitamin D and your vitamin E, magnesium, RBC. My goodness, what's your selenium level and your omega-6 level? All of these are targeted. We're looking at lab-based levels and we're raising them to a therapeutic dosing. And we're going to bump the dosing based on the response, and then we consider nutraceutical challenges. We have recorded 4 lectures about how to do a nutraceutical challenge using like high-dose curcumin, high-dose glutathione, high-dose vitamin B1. Those are called nutraceutical challenges. And it's no different than if you had a big inflammatory response and you went to your doctor and they said, hey, I want you to take prednisone for 7 days. Well, we're going to do that with a nutraceutical. It's amazing what happens when we do that. Okay. Then we look at markers of inflammation like CRP, uric acid, and AG ratio. We've got to look at their thyroid. It's not just a TSH. We got to look at antibodies because we know if there's autoimmune disease there, it's going to negatively impact their brain. We look at sex hormones like follicle stimulating hormone, estradiol, total testosterone, DHEA, and pregnenolone. And we compare the risk of treatment against the risk of psychoactive meds. It's not uncommon that when I say to one of my colleagues, hey, why don't we try a hormone? And they say, oh, that's too risky. I would never do that. And I say, oh, really? And your patient's on Seroquel. So you're telling me that hormones are too risky, but if I look at what the FDA says about Seroquel, it says it should never be used in individuals with dementia because it causes death. So how is it that they can tell me that hormones are too risky, but Seroquel's safe? You see my point? It just doesn't make a lick of sense, right? There was the new director of the FDA. He's been appointed to be the director. His name is Dr. McCary. He wrote a book called Blind Spots. And in his book, Blind Spots, the subtitle is When Medicine Gets It Wrong and What's the Effect on the American People. And he says the greatest blind spot in our era is how we address hormones. That is written by the director of the FDA, and most doctors have never heard of him. They don't know the science, the theory. We've got to help our doctors understand that. Then we can go to smart supplements. You guys have heard of nootropics. Do you know how often someone comes to me and says, hey, Randy, I've been taking Focus Factor. I bought it at Costco. What do you think of Focus Factor? And I'm like, I like it. Keep taking it. It's got a little bit of caffeine. You got to be aware of the caffeine, but there's a ton of those nootropics. They include things like CDP choline or acetylcholine, vinpocetine, flavonoids, B1, nicotine patches, glutathione, methylene blue, and all the challenges that I talked about, right? NAD. Just Monday, one of our clients said, you can't believe the response my husband just had with NAD. And I thought, oh, I've been aware of NAD for a while, but I haven't done IV NAD. Maybe I need to reintroduce that as a potential, okay? Again, these are targeted therapies applied individually when it's appropriate, and they're optional based on how much energy or effort or desire or financially the families want to use. I want you to know that this is not uncommon for me. I had a husband of his sweet wife. He's in his 80s. He came to my office and said, Randy, I'm a millionaire. I have millions of dollars in the bank, and I'm willing to spend whatever you think I need to spend to keep my wife at home. You know what I helped him do? He bought a hyperbaric chamber and he put it in his basement, and he does hyperbaric therapy with his wife every day, and he's 80 years old. Isn't that cool? Families want options. They want treatments. They're willing to spend a little bit of money for these types of interventions. Then we talk about non-pharmacological interventions. Well, what are those? I already talked about exercise with oxygen, David Delight Pro, pulsed electromagnetic therapy like a beamer. There's a ton of devices on the market. Transcranial magnetic stim. I had a retired professional football player from California who called me and said, hey, would it be safe if I did transcranial magnetic stim along with all your therapies? And I'm like, oh boy, would it ever. It'd be amazing. You could totally do that. Red light therapy like helmets. We spent $50,000 on a red light helmet about 6 years ago. You can now buy a red light helmet for $1,800, and they're amazing. They do great things. A community would be so wise to invest in a red light helmet, and then they could be used 100 times a day on all of the residents. Far infrared sauna, hyperbaric therapy, interactive metronome, balance training with a balance board, VOMS assessment, convergence training, Brock string assessment. These are so easy to do. They can be folded into an activities program. Just think if activities program was, let's play bingo in the morning and then everyone does exercise with oxygen. Let's do a coloring program this afternoon and divide up our hyperbaric treatments. Let's do transcranial magnetic stem while everyone sits on their David Delight Pros. These types of interventions are affordable, they're easy to employ, and they can be done in group setting with seniors who are looking for anything more they can do to strengthen their brains. Okay? They can be synergistic. What I mean by synergistic is that when we add one therapy to another therapy, instead of 1 + 1 = 2, 1 + 1 can equal 5. I got an email this week. I wish I could share it with you, but I don't have the client's permission to share it. They joined our service and had a MOCA score. They've been on it for 3 months, and they repeated their MOCA score, and they've gone up by 7 points. And the wife couldn't be happier. It's like, oh my gosh, how does this happen? There's concussive therapies and peptide therapies. I did a telemedicine consult with a family from California who's been on low-dose GLP-1s and CMAX. These are peptides, cerebral lysin, BPC 157. These are obtained through pharmacies. They're not considered prescription medicines. They're considered prescription peptides. And can they make a difference? There's some regional evidence that some people become highly responsive to them. So when someone moves into a memory care unit or an assisted living center, if the treatment is we lock the doors because there's an elopement risk, we have an activities program, excellent staff, and prescription medicines, I'm grateful because that's the starting point. But if that's all we've got, we're missing pieces that could enrich the lives of our seniors. There's more that can be done. There is a proactive approach, and there's things that you probably have not tried that we could implement, and we want to help you to see what might be missing. This is a graphic that I often use when I'm lecturing to communities, and a community says, well, Randy, what can I do? This is kind of my little graphic that outlines the entire lecture that I just talked about. It's a one-page summary of the interventions that we try to make a difference. Now, I'm going to finish with an opinion statement. My opinion statement is the following. Healthcare providers and community directors all recognize that antipsychotic medication should not be used in residents with dementia. But for the most part, they don't know what else to do. They don't have any other ready solutions. But our experience, we have 40 years of combined experience at A Mind for All Seasons, that evidence-based interventions between caregivers and prescribers that are initiated proactively can prevent those crises. They can prevent sundowning and all the misery that comes with the end stages of dementia. These interventions change the way seniors decline, especially when associated with dementia. And they improve the quality of dementia care in senior living and memory care centers for those residents living with dementia. If you're taking care of a spouse who has dementia, they can improve the lives even in our home, maybe keep them at home longer, make our lives a little bit simple, a little bit easier. I should never say simple because taking care of dementia is not a simple process. I want you to know that I would be a hypocrite if I told you that I never use medications to slow or moderately sedate an individual, but it's never my first approach. It's not my starting point, it's my ending point. And I think that's where I have strong opinions and differ with the current standard, because oftentimes that's a starting point. Hey, if they start having problem, use this medicine, Seroquel. We should be really cautious and thoughtful about that. So anyway, this is the email for our patient-centered review at A Mind for All Seasons.